Hello and welcome to the session today. My name is Jane Houston and I'm the Clinical Director of Midwifery and Women's Health at Frontier Nursing University. It gives me great pleasure to introduce my colleague, Bethany Cook, who's a women's health nurse practitioner and certified nurse midwife, who graduated from Texas Women's University for both bachelor's and master's degrees in nursing. She earned her certification as a women's health nurse practitioner from UT Southwestern and her postmaster's certification as a nurse midwife from Frontier Nursing University. Bethany grew up in rural East Texas and practiced there for over 10 years. She currently lives in Oklahoma City, where she and her husband work for Planned Parenthood Great Plains. It is my honor today to introduce you all to Bethany Cook. Thank you so much.
Thank you, Jane. So today's lecture was really based upon creating your own practice, and I've actually never done that. But I've always worked in practice and been hired by a bigger company, whether it was the hospital or Planned Parenthood. And one of the things that I learned from the very beginning was I needed to create a niche. So I think that this is an important lecture for anyone going into practice, because if you're joining a big practice that already has plenty of clients for you, or you're in a smaller atmosphere and you really need to find something that relates to your patients, I think any of these points could be taken in order to create that niche for yourself. And I've been in practice now for 13 years, and I've been in different settings, and as a nurse practitioner at first, and then as a nurse midwife. And I can just share with you my experiences and what has helped, and hopefully that you can take something away from this lecture. You know, at first I was a labor and delivery nurse in a small hospital in East Texas where I grew up. And after about a year, I had known that I wanted to be a nurse midwife, but I was really concerned that, you know, maybe I didn't have enough experience. And so at my first annual review with our clinical nurse manager, she said, "Okay, well, it's been a year. You said you were going to leave me and go become a nurse midwife." And I was excited about that possibility, but also, quite frankly, I was pretty terrified by the whole idea of being responsible for a labor and birth on my own. And so the thing we came up with was that I would just go and become a nurse practitioner. And I did that. And ended up staying in that community and working for the next 10 years as a nurse midwife, and then as a nurse practitioner, and then a certified nurse midwife. So I'm a women's healthcare nurse practitioner, and at 25 years of age, I started practicing as an NP with this physician and in the same hospital that I had been a labor and delivery nurse. So it was exciting for me. I had actually had the privilege of laboring many of our patients and helping with their birth process when he delivered their babies, and then got to see them on the GYN side of things later on as a nurse practitioner and help them through their GYN care. And the next time they were pregnant, the way that it worked in our office is that I saw all of our new OBs, and he came in and did their ultrasound. So I did their exams and their teaching, and then he did their ultrasound, and that was their first OB visit back with us. We would take turns through the OB process while they were pregnant, and then I always did the first postpartum visit with the patients. And so that was exciting, and it was exciting for me to be a labor and delivery nurse for some of those women that I'd carried through the entire process. And so after doing that for a few years, I just really ached to become a nurse and to be able to do that on my own. So in the beginning of my practice, like I said, the doctor and I switched off during OB care. And I started to have a following of women that I would see for their GYN care most of the time. And that was exciting. And my niche at that point, early in my practice, was that I was young and I was female. And so the physician actually a lot of times would see mom if mom was 35, 40 years old, and I would see daughter for her maybe first pelvic exam. That was back when we did PAPs at 18 years of age, or 3 years after first intercourse. So I saw a lot of young women. It was a challenge because our OB and other people in our community believed that women that were not married were not having sex. There were some things that we had to angle around because, you know, you have a woman coming to you telling you that she's sexually active, and yet her mother won't let her be on birth control because that would be giving her permission to have sex. And so condom use was a big part of my practice. I did some things that were maybe a little bit controversial, but were definitely part of the guidelines. My physician said that we didn't have anybody with chlamydia because these young girls weren't having sex. And I was taught that any woman under the age of 26, you really should be testing and screening for these things. And it was amazing, the chlamydia outbreak that we came up with once I started testing for chlamydia. We started finding it. And one of the things I told my patients at the time, because they were scared that, oh my gosh, my mom's going to get my Blue Cross Blue Shield back and see that you tested for gonorrhea and chlamydia, and she thinks I'm a virgin. I would say, well, you know, blame it on me. And tell them that I follow the guidelines and that any woman under the age of 26, I'm going to screen regardless. And then they can be mad at me about it, but I want to make sure that you're safe. And I think that sometimes as a nurse midwife or a nurse practitioner, you are the one that is really fighting for your patient's autonomy. And that may be a way that you have to do it. Sometimes you have to be the bad guy because you're not the one going home to mom like the patient is. So my first niche was being female and being young. And so I saw the younger women. I'm also bilingual. I speak Spanish as well as English. And so there were many times where by having that opportunity to speak to the woman in Spanish, she then sent many referrals my way because there were other women in our community in small rural East Texas that also spoke Spanish as their main language. And I've noticed over the years that women, when English is their second language, they may speak to me in English in a non-stressful situation, but when it came down to labor and birth, or when it came down to their exam, they went back to speaking Spanish. And so I was able to bridge that gap and continue their care and continue to be supportive of them, regardless of which language we were speaking. So that was something that was, you know, a niche in my practice. One of the things I think that I took for granted as a nurse practitioner was that people in our little town pretty much had an understanding of what nurse practitioners were. Now, I will say that there were times where they would ask me if I was in medical school or was I training to be a doctor, because I was a nurse practitioner, and I just very gently explained to them that I was an advanced practice nurse, not a lesser form of a physician. That the practices were different. And so I never wanted to take away or insult my physician, but I wanted to stand up for myself and to explain to the woman the differences between a nurse practitioner and a physician very gently. This came apparent when I was a nurse midwife. My husband is an OBGYN, and we were in the same practice. And I kept telling him, you know, people in this community, they don't know what nurse midwives are, and he didn't really understand that. We were set up in this practice as competitors, and he had his own, you know, practice to build, and I did too. And so at one point he told me that a woman came in for her first OB visit, and after being screened through our front office, she asked him, "Now, I'm under the impression you have wives that deliver your babies." And he was like, "Wives?" Yes, the woman on the phone told me that you had wives that deliver your babies. And he was like, oh, the midwives. The midwives deliver babies. Yes, they're under the same umbrella, but in a different practice. So that explained to me right away that we needed to educate the public as to what nurse midwives were, because I was the first nurse midwife in that rural East Texas setting, and we brought on another nurse midwife as my cohort, and women didn't know what they were. And I think that Frontier set us up very well for that. There was a project that I did for Frontier where I had to survey the managers of the hospital, the doctors. There were only 3 in our community, but I had to do a survey of the hospital administrators and the nurses in OB and the other physicians, the other OBGYNs, and get an understanding as to what do they believe nurse midwives are. And it was very insightful, because this hospital, I had been a nurse practitioner there for 10 years, and they sent me to Frontier to become a nurse midwife, and because they wanted a nurse midwife, but they were shocked when I came back and I wasn't a miniature version of their obstetricians. I was a nurse midwife, and they didn't understand why there was a difference between the types of practices. And I got into that with them and explained, and it was a very good project where I could then come back after the survey and explain and do education. There was also education with our labor and delivery nurses. They had known me for my entire career, but they didn't know, are they allowed to take orders from me? Who attends the birth? Who do they call? How does that work? And who cleans up afterwards? As a labor and delivery nurse who worked with them, I cleaned up afterwards just as much as they did. I considered it something that was part of being a nurse person, and they appreciated that, because that's something that the physicians don't typically do. So what I would say is there's definitely, regardless of whether you have midwives in your area or not, there's definitely a niche where you can come in and educate the public. My cohort nurse midwife and myself went to different organizations. So we went to MOPS, the mothers of preschool and school age children, and we gave lectures about what nurse midwives are and how we educate and how we attend birth. And that doesn't mean we stand in the corner while the doctor delivers the baby. What does that actually mean? And so actually we received a lot of feedback from that. We did have many women from those MOPS groups become our patients, and that was a privilege. We also went to Rotary meetings, Lions Club meetings to educate the public. It wasn't even just women that were our target, it was men as well. One of the projects that I had to do through Frontier was to reach out to the health department and find what needs that my community needed from the health department or in general. And so that made contacts for me at the health department. And that was a good thing as well, because women after birth would go in for their WIC services or maybe STI screening. And then the health department was then more apt to refer them to myself and my cohort because they knew that we existed. I had to do another project for Frontier where I gave a lecture at a nursing school. So I would say, reaching out to some of your local nursing schools, colleges, if you can be a guest lecturer somewhere, I think that that's important as well, just to get your name out there and to educate the public and the nurses, especially. They're going to be your biggest advocates. What is nurse midwifery and what is it that you do, or a nurse practitioner? Sometimes I think now people know more about nurse practitioners and nurse midwives than they did 12 years ago when I started, of course. But I think that it's good to get your name out there, have exposure, you know, and even be a preceptor to some of these nurses as they go through their nursing school practice or nurse practitioner practice. I brought in a lot of clients that way, and it was just because I was a part of the community and I was reaching out. And it was, I have a saying that I try to meet the woman where she is, or the person where they are. And that has been always the way that I have practiced. So does it mean meeting the woman where she is because she's having a breakdown during this labor and you've got to get her focused enough to keep going? Is it meeting her where she is because she wants an epidural? Is it because she wants a cesarean birth? Is it because she lives 50 miles away from your hospital? Is it meeting her emotionally or physically where she is? I think that, you know, at least for me, that has been a benefit of thinking that way, is to be able to meet the person where they are. And I'll get into that a little bit more as we go on. One thing that I've been a big proponent of, I'm a nurse practitioner, a nurse midwife, and I'm also a registered nurse first assistant. And I did that program. It's a year-long program where you can become a first assistant in surgery, and you can bill for those services just the same as any other surgeon in the field. And I did that to become a more marketable nurse practitioner at the beginning. As an RNFA, you can actually assist in any type of surgery, whether it be a hysterectomy, a C-section, a radical neck. That was very interesting. I worked with an ENT on a 12-hour surgery where he took down the face to the neck and had to remove a cancerous tumor. So to me, being an RNFA was, in essence, in the beginning, to become a more marketable nurse practitioner. And I would say, you know, I'm a women's healthcare nurse practitioner, so my options are limited as far as what I can do in the office, and then become, you know, an RNFA in the field, and then come back and do post-op care. So I was limited to, if I was going to do full circle, I would see the woman in the office, I would assist the surgeon, most of the time my husband, in hysterectomy, and then I would see the woman post-op. So I was able to do full circle of care in that regard. I remembered what the uterus looked like, whether there were fibroids, whether not. Was it difficult to take down? Is that why she had so much pain post-op, or what have you? But as a family nurse practitioner, I think the RNFA adds even more, because you could do anything. You can harvest veins during like a bypass. You could work in all types of surgical services, whether it be gastric bypass, or even in a family setting if you have a family doc that's also a surgeon. Or even in a general surgeon's office. So to me, I did it to become a more marketable nurse practitioner. And in the long run, it helped me with my practice, in that I was always able to tell my women that came in that were maybe a repeat C-section, or maybe there was a reason why we were planning for a C-section for this birth. I'll be by your side no matter what, because we're scheduling this. The only way that I wouldn't be by your side for this birth would be if you came in labor and I was not on call, and then my cohort would be the first assistant in that surgery. So I really love surgery more than any nurse midwife should ever admit. But it was definitely a great program. I was grateful that I went through it. As a nurse midwife, you can go through a similar education. I think it's 60 hours with the ACNM, where you can assist in C-sections and receive billing for that. You can't do hysterectomies. Any RN can stand in the surgical field of the surgeon and work under his direction. But if you are an RNFA, you can bill for those services, and you have a lot more education as far as what you're doing. He doesn't have to tell you what to do if he's working one side and you're working the other, or what have you. So that was something that I was really glad that I had added to my practice. Also, as a nurse midwife, I was firm in my belief that if we were going to help this woman through the birth, regardless of how it happened, that we could leave her with something more tangible than staples. At the time that I went through midwifery school, I was the youngest person on the group of pediatric OB providers, and I was of childbearing age, and everyone else was much younger, much older than me. And they didn't sit around on the weekends drinking wine with their friends, listening to their birth stories, and I got plenty of those. And our OBs that we worked with, my husband included, closed with suture or closed with staples. And I had women that were my friends that would come in and say, you know, I had a C-section and my scar was big, and I have these dots on either side of my incision, and it really bothers me. And so the move that my cohort nurse midwife and I did was to go ahead and suture the skin shut. It does take about 8 minutes longer for a C-section. I will tell you, some surgeons will be upset about that, but they can write their note and they can call and check on the baby. And by the time they get done with all of that, you'll be done with your suturing of the skin. I mean, it just really leaves a nice, much better looking scar for the woman. And it was something that we insisted on as nurse midwives, and we were fought. But we came through in the long run and said, you know, this is something that we really think is valuable for our patients, and that's what we want to do for the midwifery patients. So, you know, my cohort nurse midwife was not an RNFA, as I've said before, but what she thought was valuable to reach out to the community was to become a lactation consultant. That was something that was really in her heart to do. And it's a lot of work to become a lactation consultant, but you may find a niche in that way by becoming a lactation consultant and helping women through their breastfeeding processes. So I would also suggest that would be something that you may create a niche. You may create a niche just because you're female and just because you're a nurse midwife, and that would be great. These are just some suggestions when you're navigating that path. You may come in contact with some very thick-skinned, very good old boy type behavior from your hospital, from your board, just depending on what kind of practice that you're joining. I had some blowback. There was a day that we were in perinatal committee meeting, and my cohort and I wanted to explain that while we're remodeling OB, could we put in a birthing tub? And, you know, she and I were the only two OB providers that had witnessed water birth, and we knew that was something that women felt comfortable in, and this was something that nobody else was doing in our community. And we brought it up, and the man that I had worked with for 10 years, the one that I started off with, I was his nurse practitioner, said we may as well buy a trough from Tractor Supply and deliver babies in that, because it was disgusting. So the physician that I had been his nurse practitioner for years and who I really looked up to had said we may as well go to Tractor Supply and get a feed trough and deliver these babies in there. And usually I cry during that story. I tear up. I get really upset because it was really hurtful, I felt like, in that setting, and really showed that sometimes your practice is limited to what your OBs will do. And if you're in direct competition with them, they're not going to be open to ideas like water birth. And so I hope that you're able to bring that service to your patients. Just know that sometimes you're in a political situation that just it's not ready. 2 years later, I was in a different situation in the same practice. My husband was chief of OB, and he was like, I really think you ought to bring up this midwifery thing again. I had asked him to read Spiritual Midwifery, and I had actually called a C-section earlier that day, and he came in to be my surgeon, and he what is called pimping in medical school. He pimped me over the procedures for shoulder dystocia, because he had a woman that had a previous shoulder dystocia, and he had been badgering her all day about having a C-section. He probably has a 60% C-section rate, and he doesn't apologize for it. So we're quite different in the way we practice obstetrics. But while we were scrubbing in, he asked me, you have a shoulder dystocia. Go. What are you going to do? And so I explained to him the maneuvers and what you do during a shoulder dystocia, but then I added the Gaskin maneuver, and he had never heard of that before. So we did the C-section on my patient, and his was still in labor. And over the next 4 hours, as she was in labor and he wanted me nearby in case we did a C-section, I watched him change quite a bit. He had read a letter that was written by a woman who couldn't decide how she wanted to have her baby. So the layperson was writing her story about how she chose her birth attendant, and she didn't know if she was going to go with a certified midwife in a home birth, a certified nurse midwife in a hospital, or an OBGYN in a hospital. And she ended up going with a certified nurse midwife, and she had a C-section, and she just explained what her experience was, and in that time explained how midwives stay with their patients during labor and how supportive that we are. And my husband didn't realize that at the time that's the kind of the difference in care that we give. And so he read that article, he stopped badgering his patient, and she delivered vaginally with no problems. And he changed after that and really started listening more to what the midwives had to say. He had been taught by nurse midwives when he was in medical school, and he had a great appreciation for them as to what's normal in birth. And I was glad that he had that in his training, because I wasn't quite so sure. But we were able to transition. He wanted me to bring up labor and water birth again, but we still had the same board of directors, and it wasn't something I could go to emotionally at that point. And then we ended up moving on. But water birth may be something that you're able to provide as a niche service in your department, and maybe in your labor and delivery, or maybe if you're doing home births or birth center births. Another thing that I've done as a niche was bioidentical hormone replacement therapy in the form of pellets. I went with a company that I started doing a lot of bioidentical hormone replacement for menopausal females in my practice, and my GYN practice started growing so much because I would have pregnant women in my office, and their mothers would come and see the advertisement for the hormone replacement and be interested in that. And I actually gained so much of a GYN following from that my husband had to sit down and remind me that I was a nurse midwife and that I really needed to bring in OB patients. And I was like, well, those hormone patients, they don't call you at 2:00 in the morning to come deliver their pellets. So I'm happy with that. But at any rate, it really increased the amount of patients that I was seeing, and I really felt happy with that care. Menopause was one of my least favorite subjects, and up until that point. And when I could actually do something to help these women other than antidepressants and Premarin, it was amazing to see the differences in them, and it was exciting to help them through that process. So we even at one point we worked in a bioidentical hormone replacement clinic for about 3 years, where that's all that we did. And of course, you just see that nonstop of how patients feel so much better through the bioidentical hormones. And sometimes people will seek you out as a nurse midwife because they have a preconceived notion that you're natural, or maybe you don't see things the same way as the medical community. And I think that's something that you have to determine for yourself and the way that you're going to practice. Like I said, I've been a nurse practitioner for quite a bit longer than I've been a nurse midwife. And so maybe there's some instances where I practice maybe more of a medical model. And there's some instances where I practice more of an advanced practice nurse model. So I think that's just up to the person and how you want to go along with or how you want to model your practice. Another thing that I did when I was in the bioidentical hormone clinics was Botox and fillers. That's also something that you can do if you reach out to a med spa and you want to get your name out there. Botox and fillers, usually a day, 2 days of workshops, and you can be certified to do those things if that's something that you want to do in your practice. Of course, you cannot do that for your pregnant ladies and your breastfeeding moms, but postpartum, if that's something that a woman wants, or during your GYN practice, then that's a good way to bring in business and have a niche. Not many obstetrician gynecologists are going to see that as a niche in practice. And so that may be some way that you're able to bring in more clients to your own practice. One of the other things when I was researching becoming a nurse midwife, I wondered if, because I was already a nurse practitioner, should I be a certified midwife or a certified professional midwife, or should I be a certified nurse midwife? And ultimately I went with the certified nurse midwife, but I also had friends that were certified midwives, community midwives in our surrounding area. They maybe an hour away, that they did home births. And I reached out to them at once I became a nurse midwife and was like, hey, if you have somebody that graduates from home birth, they can still be attended by a midwife, but in a hospital setting, if that's something that, if their healthcare warrants that, or if that's what they need. And so by bridging this connection with the certified midwives in my community, I was able to see some of their postpartum women for birth control needs. I was able to see them for maybe urinary tract infections or sinus infections, or if they were a woman that graduated from a home birth situation, and the woman still wanted a midwife to attend her birth, then it was a more seamless effort for us than it would be to bridge the gap from a certified midwife at home birth to an obstetrician in the hospital birth, quite possibly, just depending on the obstetrician. But I think that reaching out to your certified midwives and letting them know your skill set and what you would be willing to do to help them out and their patients, it goes a long way. And I definitely received some referrals from the certified midwives in that area. Join your state and local organizations. As far as nurse practitioners and nurse midwives go, you can understand a lot more about what's going on in your state. I'm originally from Texas, and we had a moratorium after gaining prescriptive authority that we couldn't ask for anything else for 8 to 9 years. And once we got past that moratorium, I went with several other nurse practitioners, certified nurse midwives, and CRNA colleagues to the Capitol, to Austin, to lobby for autonomous practice. And that's not something that we got in the first or second session. They still don't have that in Texas. But now I'm in Oklahoma, where we do have autonomous practice. We don't have to have a supervising physician. We do have to have a collaborating physician for prescriptive authority, but it's all going to depend on your state laws and how you're regulated as to whether or not you have that. But that may be something that you're passionate about, and you want to join in with the local and state organizations to find out what's going on and what and how it impacts you and your practice. As Jan had said before, I work for Planned Parenthood now. My husband and I both do. He's our medical director. And one of the things that I've found a niche in this practice is abortion and transgender care. And as a nurse midwife and nurse practitioner, I'm considered quite an expert in hormones. Now, I have traditionally done this in the menopausal female set, as we talked about, but having that grasp of hormones and how they work, and the grasp of birth control and how it works, has really helped me to be able to see our transgender patients and to meet them where they are and make a plan of care that's right for them. If you have a woman that's doing a transgender to male hormone, some of the things that you need to ask that woman is if she's having sex with somebody that has a penis. And if that's the case, then a progesterone only method may be her best method of birth control. A lot of times a Mirena would be a good thing. It's something that she doesn't have to think, or he doesn't have to think about for 5 years or so, but is actually a good birth control method. And I say the progesterone only because you don't want to add estrogen to a situation where you're really trying to decrease the estrogen effects on the woman's body. And, as she's transitioning to a male and the testosterone, you don't want to add estrogen into that mix if you can help it. So a progesterone only method is best, like the shot, the Mirena, the Nexplanon, or the progesterone only pill. And that's something that you're just going to have to sort out with your patients. Another misconception sometimes is with your male to female transgender patients, where they believe that once they have enough estrogen that they're chemically castrated, which is true, but we're not monitoring that. So they could still father a child if they were having sex with a woman or person that had a vagina. So these are things that I think that as a nurse midwife or a women's healthcare nurse practitioner, you can bring these skill sets to the table, and something that you can really help that group of people, because they don't always know where to go, and they don't always see a friendly face. And if you're somebody that can help them in their healthcare, then they're going to be very grateful for that. And you may find that that's your niche. In abortion care as well, as a nurse midwife, we see ourselves a lot of times helping the woman through a labor and birth process. But sometimes, I found myself most humbled when I was doing sonograms for women that were terminating their pregnancies. You may be the only person that woman ever tells that she's had this procedure done. And she may have a lot that she needs to talk to you about emotionally and physically. And also, remembering that, to be a good listener, and to also make sure that you try to explain to her what her birth control needs are moving forward. And so that in most recent years has been the way that I've practiced in my niche, has been transgender care and abortion care. Some states, the nurse midwife or nurse practitioner can actually perform medical abortions or surgical abortions, and or both. It depends on the state laws, and so you would have to research that. But I think so many times as midwives, we really see ourselves as a labor and a birth person, attendant, but there's a need for abortions too. And you may find that you're able to provide that service to your patients, whether you work for Planned Parenthood or for another organization, but that may be something to consider. And I don't think that we always consider that as midwives, but it's definitely something that has come forth in my practice, and something that I'm humbled to help a woman through that process. Another thing that I did in practice back to when I was in East Texas, and we've talked about, meeting the person where they are, whether it be emotionally or physically. So my counterpart and I both took we would each take a week of call. When I was not on call, I didn't see patients in our normal office that was right in the parking lot of the hospital. I actually went to outlying clinics. And so we were in rural East Texas, like I've said before, and I chose different clinics that were about 20 minutes away and from the main office. And I opened up one clinic in a chiropractor's office. One clinic was in a hospital based system. It's a different hospital than I worked for, but they had room and they were able to rent me a space. I also worked with a physician he was a renal specialist, but he worked for my group and he was in a different town. And so I was able to provide OB care out of his office as well. So I physically met the women where they were because maybe they were 50 miles from the hospital and they couldn't always come in to clinic that far for a midwifery visit during their prenatal care. So I would see them most of the time in their outlying clinics. And then, you know, if it was that they needed ultrasound for like the 20-week ultrasound, and then they would go in to the physician for that, or if they needed to pre-register in the hospital or that. But, you know, they were able to be attended. I was able to attend their birth in the long run and then take care of them as GYN patients after the fact. It took a couple of years to support that practice. And there's sometimes when you fail, you know, like I said, I failed with the introducing water birth at our hospital. It was traumatic, I felt like, and it was a setback, but, you know, I wouldn't have known unless I tried. And with the 4 outlying clinics that I started, 3 were still functioning when I left. And one was just, you know, we would spend half a day there and we maybe saw 3 patients. And that town in particular, the reason I chose it was because we had women that would drop in with no prenatal care from that town. And I was trying to develop a niche there. They didn't have many providers that were seeing Medicaid patients. And so I offered those services, but in the long run, I didn't have very many women that showed up to their prenatal visits. They still dropped in to OB, you know, at 40 plus weeks. So I ended up not finishing out that clinic. We ended up terminating services at that clinic just because it wasn't lucrative to the practice and it was a waste of resources. So sometimes you're gonna succeed, and then sometimes you're not gonna succeed, but you just don't know until you've tried, basically. One of the best things that I did for my practice, like I said, I was in a rural East Texas town that didn't have nurse midwives before I came along. And so they didn't understand quite what midwifery care was. They thought, even though they saw me in the hospital owned practice, that maybe I was going to attend their birth at home, or that I expected them to have a vaginal birth no matter what. And that maybe I wasn't okay with C-sections. There were a lot of things that they brought with them or as expectations. And part of my strategy was I had to inform them that they were the ones that were in control as long as it was safe. I was going to support them in their birth decisions. So one of the things that I did was go to Vistaprint, and I had a picture of myself in the hospital holding a baby that I had just caught. And so I was in scrubs. There was a lot of hospital garb behind me. And I went ahead and made maybe a 3x5 card that had that picture, and then with lots of different colored inks, you know, that I was a nurse practitioner, nurse midwife, and these are the services that I offered. And so it gave patients, you know, a picture's worth 1,000 words, right? So it gave patients a visual, and that way they weren't just so set on, oh, she's a nurse midwife, she must expect that I do natural birth, and that's not something I want, or what have you. So that was one of the best moves that I made. I put those out at my outlying clinics, and I also went around to pediatricians because I wanted to explain to them that I could see their patients as they graduated from pediatric care, or if they had a GYN need in the meantime. And so a friend of mine was a pediatric nurse practitioner in a large pediatric practice, and I had my cards in her office. And we used to say that we would rotate patients because they would come to her until they were 15, 16 years old as a pediatric patient, and then they would come to me at 16, 17 years old pregnant, and then I would send the duo back to her for the babies. Care. So pediatricians, pediatric nurse practitioners, I think that's a good way to get your name out there. Pharmacists, and other nurse practitioners. The most referrals I got was from family nurse practitioners because they weren't comfortable doing GYN care, or it maybe wasn't their favorite. And so they could send their GYN patients to me, and I wasn't going to steal them for other things like their sinus infections, but that is definitely where I ended up seeing the most referrals from pediatricians and family nurse practitioners. After I had explained that I did IUD care and Nexplanon and that sort of thing. And those are things that usually you don't find family nurse practitioners or family practice docs or pediatricians doing. So that was also another niche. To do the implant after you graduate from midwifery or nurse practitioner school, you have to be taught by the company to do an implant. It's a couple hours of a CME. It doesn't take very long to do, but if you're, I think it's a good thing to add to your practice so that you're just a more marketable nurse practitioner, nurse midwife, and also you're going to have women that know about that. Now, when I first started practicing, we didn't have that. Norplant had just recently gone out of favor. And then Implanon came along, and then Nexplanon after that. And I probably put in 3 Nexplanons a day now. So it's something that I think is important to add to your practice as you grow. So that pretty much wraps up my talk about finding a niche in practice. I hope that something has fallen on you that it may be beneficial, that you can add to your practice. 2 other things I would leave you with is it's good to have a good nurse. I had 2 excellent nurses when I was in that hospital-owned practice, and we worked together with follow-up. She had a good understanding as to what my skill set was and what I needed, and we were a good team. And I think that can only enhance your practice when you have a good nurse that understands what you're all about, and she can help to be your best cheerleader. Sometimes you may be over in a birth and she may be the one telling your patients, hold on just a second, or hey, do you want to go to lunch and come back, because she's over attending a birth right now and I don't know when she's going to come back. But having that cheerleader on your side is never going to be a bad thing. And doing good follow-up. You may do the best care in practice, and the woman may walk away from your practice saying, oh my gosh, that was great. I really felt that she met my needs and that she understood what I was talking about. But if you don't follow up and you don't let them know what their PAP results were, or some of their STI screenings, then they kind of lose that a little bit. And so in order to keep that, close that loop of communication by getting back with your patients or letting them know how they can close the loop of communication with your front office staff if they need test results. So that's my lecture about finding a niche in practice and maybe entrepreneurship, if that's something that you want to focus on after you graduate. Good luck. I think that you're going to do a great job, and Frontier is definitely going to give you the skill set that you need to get out there and start attending those births and taking care of the people in your community. Thank you for having me.